The broadcast is now starting. All attendees are in listen-only mode.
Good morning, good evening, and welcome to this webinar on hypoparathyroidism, diagnosis and advances in the management in 2020. I'm Dominique Pierrot, Science Manager at IOF, and I'm happy to moderate this webinar. Before introducing the speaker of the day, I would like to inform you that attendees are automatically muted. I also would like to encourage you to ask questions during this webinar by typing your question into the question box of the GoToWebinar control panel. I will voice the questions to the speaker towards the end of this webinar. This being said, I'm happy to introduce for this second Bonecast webinar our speaker, Professor Aliya Khan. Professor Khan is Clinical Professor of Medicine, Divisions of Endocrinology and Metabolism and Geriatrics at McMaster University, Hamilton in Canada. She has extensively published on parathyroid disease, and she has co-chaired the international workshop on hypoparathyroidism. So she is internationally recognized as an expert on this topic. Professor Khan, please, we are listening to your lecture.
Thank you very much, Dominique, and welcome everybody. It really is my pleasure to speak to you today about hypoparathyroidism, diagnosis and advances in management in 2020. So if you can see my slides and you can hear me, I'd like to begin with some disclosures, and I have received research support for the development of new molecules for the treatment of parathyroid disease as well as metabolic bone disease. So these are our learning objectives. We will be looking at how we should diagnose and evaluate hypoparathyroidism. We will talk about the goals of therapy, as well as the risks and benefits and limitations of treatment options available to us today. And we will address management of hypoparathyroidism during pregnancy. And we will also talk about initiation and cessation of PTH replacement. So we do have international consensus that hypoparathyroidism is characterized by low serum calcium in association with low or inappropriately normal PTH. And this was agreed upon beginning with the first international workshop on hypoparathyroidism in 2011, and then the European Society of Endocrinology guidelines in 2015, and also the International Conference in 2016, and most recently the International Consensus Standards in 2018, published in 2019, sorry. So how do we diagnose and evaluate hypoparathyroidism? Well, we have to remember that PTH is the main regulator of serum calcium, and PTH will ensure that we have renal calcium reabsorption, and in the absence of PTH, there will be an increase in urine calcium losses, and this will be associated with an increased risk of nephrocalcinosis, nephrolithiasis, and chronic kidney disease. Remember too that PTH stimulates the hydroxylation of vitamin D and the formation of 1,25-dihydroxy vitamin D. And so in individuals who have hypoparathyroidism, not only are they deficient in PTH, but they are also deficient in 1,25D. And 1,25D is essential for the absorption of calcium and phosphate in the bowel. And PTH will also contribute to bone resorption and mobilize calcium from the skeleton. And through these three mechanisms, it will maintain calcium in the normal reference range. And so individuals who have hypoparathyroidism due to inadequate formation or synthesis and secretion of PTH, or a resistance to the effects of PTH at the tissue level, will have a low serum calcium and a high phosphate, and they will have decreases in bone remodeling because of the effects of PTH on the skeleton. So the presentation of hypoparathyroidism depends on how long the individual has had it and the severity of the hypocalcemia, as well as the rate of onset. And so if someone has an acute onset post-surgery, it's very dramatic presentation, and patients can have tetany and seizures in the post-op period if their serum calcium is very low. Whereas patients who develop chronic hypoparathyroidism, individuals who have non-surgical disease, may have symptoms which gradually increase over time, and they may have exacerbations during times of increased calcium requirements, such as exercise or during their menstrual cycle, and they may have symptoms which are more prominent in certain times of the day. And without treatment, then these can go on to progress, and patients can present with a catastrophic event, such as a seizure, or even depressed systolic function, and have congestive heart failure or bradyarrhythmias because of prolonged QT. And the neurologic features of hypocalcemia are quite significant, with seizures, cognitive impairment, laryngospasm, bronchospasm. These are all features that can be presenting features, unfortunately, of hypocalcemia if the minor features with the muscle cramping, the twitching, the circumoral numbness are not identified and acted upon. So the biochemical profile of hypoparathyroidism is a low serum calcium, a low or inappropriately normal PTH, a high phosphate because of the loss of the phosphaturic effects of PTH, high urine calcium because of the loss of PTH with increases in urine calcium lost through the kidney, and a low 125D because of impaired hydroxylation of 25D. The most common cause of hypoparathyroidism is surgery, and 75% of patients with hypoparathyroidism have this on the basis of post-surgical disease. And if the hypocalcemia persists beyond 6 months following the surgery, it is considered to be permanent. And approximately 0.5 to 6% of the total thyroidectomies will result in hypoparathyroidism. More recent data from Powers and colleagues estimates the numbers of patients with hypoparathyroidism following surgery to be approximately 7.6%, of whom 75% were transient and 25% are chronic. And the surgeries that result in hypoparathyroidism are usually the thyroidectomies, as well as parathyroidectomy and neck dissection. There are many causes of non-surgical hypoparathyroidism. Autoimmune is the most common non-surgical cause of hypoparathyroidism. It can occur alone or as an aspect of autoimmune polyendocrine syndrome 1 in association with mutations in the AIR gene. And this is associated with autoantibodies and lymphocytic infiltration of the involved organs. We then have genetic variants, and this can result in an abnormal function or formation of the parathyroid glands. There can be infiltration of the glands with sarcoidosis or amyloidosis destroying the parathyroid tissue. Metastatic disease is rare, but has been reported. As well, radiation destruction is rare. I've seen one patient who had hypoparathyroidism following radioactive iodine therapy. There can be mineral deposition in the parathyroid glands with copper or iron. Magnesium deficiency as well as magnesium excess can impair parathyroid function. And we'll talk about this in further detail. It is very, very important to evaluate serum magnesium and to correct the magnesium deficiency or excess. Transient hypoparathyroidism can occur in acute illness or burn injuries. And we can also have PTH-resistant states with mutations in the GNAS gene, and we'll talk about this in further detail. Maternal hyperparathyroidism can result in suppression of the baby's parathyroid gland, so the fetal parathyroid gland formation may be affected and result in hypoparathyroidism in the fetus and the baby. And lastly, if we don't identify the cause, then we call it idiopathic. So there was a very nice paper in the New England Journal of Medicine by Dr. Huseby in 2018, which summarized APS1 And as we've mentioned, we need 2 out of the 3 major features. Chronic mucocutaneous candidiasis is usually the first feature which is present, and this can unfortunately increase the risk of squamous cell cancer involving the oral mucosa or the esophagus. And patients can also develop hypoparathyroidism, and this may be the only endocrinopathy in more than 80% of people with APS1. Adrenal insufficiency is also an important major feature of APS1. And we can confirm a molecular diagnosis of APS1 with DNA analysis of the AIR gene. The major features of APS1 we've mentioned, and the minor features are also important to evaluate. Patients may have primary ovarian failure, they may have type 1 diabetes, they may have celiac disease, and it's important for us to be considering the possibility of APS1 in patients who do not have post-surgical hypoparathyroidism. Then we have genetic mutations that can result in abnormal formation and function of the parathyroid glands. It could be isolated in association with mutations in the glial cell missing gene, GCM2 gene, which can result in parathyroid gland agenesis. We can have autosomal dominant hypocalcemia, type 1, and there is also type 2. And it's important for us to look at the calcium to creatinine clearance ratio. And there can also be mutations in the PTH gene. Magnesium, we've mentioned, is essential for PTH synthesis and secretion and the activation of the PTH receptor. And magnesium can bind to the calcium sensing receptor and decrease PTH release. If we have a deficiency in magnesium, this will result in an increase in PTH. But if the deficiency is severe, we actually have a paradoxical block of PTH secretion. And it is important for us to remember that intracellular magnesium is a cofactor for adenylate cyclase. And it can actually decrease PTH secretion, and it can also result in a tissue resistance to PTH in the bone and the kidney. So if our patient has a low serum calcium, it is important for us to evaluate magnesium and to ensure that we normalize serum magnesium. PTH resistant syndrome, pseudo-hypoparathyroidism, is associated with target organ resistance to PTH, and the same biochemical profile is present as hypoparathyroidism with a low serum calcium, a high phosphate. However, in pseudo-hypoparathyroidism or a PTH resistant state, there is a high PTH, and this is an association with mutations in the GNAS gene or the STX gene, and this results in impaired coupling of the PTH receptor to the adenylate cyclase enzyme. So when we evaluate our patient, we ask ourselves, are there other endocrinopathies present? Could my patient have Addison's disease? Does my patient have hypogonadism, hypothyroidism? Do they have diabetes? Do they have features of APS1? Do they have features of pseudo-hypoparathyroidism? Do they have skeletal abnormalities? Are there other features of non-endocrine diseases, such as a cleft palate or a high arched palate and a heart disease? These are features of DiGeorge syndrome. Do they have renal anomalies? Do they have deafness? Do they have the possibility of a GATA3 mutation? So we need to ask ourselves, do they have other endocrinopathies? Is this a syndrome or is this isolated hypoparathyroidism? Because we can then proceed and obtain a molecular diagnosis if we know which category our patient is falling into. And we can then go ahead and confirm a molecular diagnosis and evaluate the patient and the family members and provide them with appropriate counseling. So what are the short and long-term complications of hypoparathyroidism? We've talked about hypercalciuria, and this will result in an increase in nephrocalcinosis and nephrolithiasis and impair renal function. We can also have ectopic calcification in the lens as well as the basal ganglia. And we have been under the impression that the calcium phosphate product really determines the likelihood of ectopic calcification. but we've recognized that this may not be the case, and it may be more related to the elevations in phosphate just by themselves. And we do have data internationally demonstrating hyperphosphatemia as being associated with an increase in the risk of intracerebral calcification. And we certainly saw this in our Canadian National Hypoparathyroidism Registry, and we presented that as an abstract at ASBMR. Patients can have an increased risk of seizures. We have not seen a uniform increase in the risk of fracture, and we have not also seen a consistent uniform increase in mortality. Dr. Mitchell and colleagues evaluated 120 charts in a tertiary care hospital and published their findings in 2012 and documented that renal calcification was present in 31% of individuals with hypoparathyroidism who were imaged, and 52% of individuals who had CT of the head completed had basal ganglia calcification. So these numbers are fairly large. And if we look at how many people actually have chronic kidney disease and compare them to healthy age-matched controls, again, data from Mitchell and colleagues, we can see that the numbers of individuals who have chronic kidney disease is significantly higher in comparison to healthy age-matched controls. So the complications of hypoparathyroidism were more clearly elucidated from the Danish patient registry, comparing cases with controls. We can see that renal complications are prevalent with a hazard ratio of 3.67. Hospitalization secondary to seizures was seen in post-surgical and non-surgical patients with hypoparathyroidism. Cataracts was seen in the non-surgical hypoparathyroidism patients with a hazard ratio of 4.21, but they were not seen in the post-surgical. There was no increased risk of cardiovascular disease in the post-surgical, but they were increased in the non-surgical. And neuropsychiatric illness was increased in both groups, post-surgical and non-surgical. Hospitalization with infections are increased in patients who have hypoparathyroidism, and our patients who are being treated with PTH, and we're evaluating these patients prospectively, will actually comment and say that, you know, before I started PTH, I noticed that I had more frequent infections. So these are just anecdotal case reports, but when we look at the data from patient registries like the Danish patient registry, we can see an increase in infections. We have not seen an increase in overall mortality, and there was overall no increase in fracture risk. Similar data coming out of Scotland. All patients with hypoparathyroidism had an increase in the risk of epilepsy and cataracts, and there was an increase in mortality that was seen in the non-surgical hypoparathyroidism group with cardiovascular disease hazard ratio 2.18, cerebrovascular disease, infections, again, we're seeing them, mental health illness, and hypoparathyroid patients had an increased risk of renal failure. And higher levels of calcium were associated with renal failure as well as death. So what are we advised to do? Well, the European Society of Endocrinology guidelines by Bollerslev and colleagues published in 2015 advise us that we should proceed with renal imaging if there is a history of renal stone or rises in creatinine. And a brain MRI would be advised by the International Consensus Group, published in 2019, if there are neurologic features of cognitive impairment or seizures. And we need to be cognizant of the complications of hypoparathyroidism. So our next learning objective is, what are the goals of therapy? And what are the risks, benefits, and limitations of pharmacologic intervention? So the goals of therapy are to prevent the signs and symptoms of hypocalcemia and to maintain serum calcium in the low normal or slightly below normal reference range. We want to keep the calcium phosphate product less than 4.4 or 55 milligrams squared deciliter squared. We want to avoid hypercalciuria. Hypercalciuria is a problem. We want to avoid hypercalcemia that is detrimental to renal function. And we want to avoid hyperphosphatemia that contributes to ectopic calcification. We want to give our patients calcium supplements, and if we give it with food, this can act as an excellent phosphate binder as well. Calcium carbonate is 40% elemental calcium, and calcium citrate is 21% elemental calcium, so it requires more pills. And the pill burden is significant for our patients. But calcium citrate is useful if our patient is on a PPI, because we know that calcium carbonate is best absorbed in an acidic environment. Patients may require 9 grams of calcium a day, and we give this in divided doses, best with meals. And I ask my patients to keep calcium supplements with them and make sure they have it with breakfast, lunch, and dinner. And if they're eating, then they can take an extra calcium supplement, depending on how they're feeling as well. We want to monitor them closely, but we want to emphasize that calcium should not just be taken as a lump sum in the morning or at the end of the day or whenever they remember it. Whenever they eat, they should think about calcium supplements. And a very nice paper by Dolores Schoback and also by our group outlined the management of the conventional therapy of hypoparathyroidism. We recognize that elemental calcium can be given 1 to 2 grams 3 times a day or more as necessary to control symptoms. Calcitriol is given twice a day. It has an onset of 1 to 2 days and an offset in 2 to 3 days. Alpha calcidiol is not as potent as calcitriol, and its potency is about 50% of calcitriol. It has an onset of 1 to 2 days, but a longer offset. So patients who develop toxicity will take a longer time for their serum calcium to normalize if they have been on alpha calcidiol. So I like to switch my patients from alpha calcidiol to calcitriol, and if you are switching, you have to ensure that the dose is adjusted because calcitriol is more potent. Hydrochlorothiazide is very helpful, and we'll talk about that in a few moments. And it's important to correct magnesium. We do have 2 PTH molecules available for us at this time. The PTH 1 to 84 was approved by the FDA in 2015 and in 2017 in Europe. And the 1 to 34 has not yet been approved, but there is very good data by Weiner and colleagues illustrating the benefits of 1 to 34 in patients with hypoparathyroidism. Thiazide diuretics, as we've mentioned, we recognize that these molecules can lower urine calcium excretion, and they enable us to lower the calcium supplement doses. The effects on the renal complications in hypoparathyroidism need to be further evaluated, and we're not fully aware of this at this time. So what are the limitations of conventional therapy? Well, patients do need to take large numbers of pills every day. Large doses of calcium and large doses of activated vitamin D will further increase urine calcium losses in the absence of PTH, and they will increase the risk of nephrocalcinosis and renal failure. It's important for us to monitor that phosphate because as the calcium phosphate and the phosphate levels rise, we can see an increased risk of soft tissue calcification in the kidney and the lens and the basal ganglia. And, you know, I tell my patients with hypoparathyroidism, you're on the calcium roller coaster. You will have days where your calcium is high. You'll have days when your calcium is low because you're trying to correct the hypercalcemia. You're going to cut back. You might overshoot, become hypocalcemic. You start increasing your calcium supplements and increase calcium and the activated vitamin D, and you become hypercalcemic. So our goal is to get them off this calcium roller coaster with the ups and downs, because these wide fluctuations in serum calcium may result in hospitalization for patients. One of my patients took a year for her to see me because every time her appointment came up, she was in hospital. So it's important for us to recognize that this has a major detrimental effect on quality of life. And we recognize that. There are impacts also on the skeleton with decreases in remodeling and a decrease in cortical porosity and a decrease in bone formation. And at this time, fracture data is limited, because the numbers of patients that we are evaluating are small. But the low bone remodeling may be associated with impaired bone strength, but this does require further study. So far, it would be fair to say that we do not have evidence that there is a uniform increase in the risk of fracture in patients with hypoparathyroidism. As I've mentioned, we have two PTH molecules available for us today, PTH1 to 34 and PTH1 to 84. You'll note that the maximum effect, the peak effect of 1 to 34 is seen at 4 hours. The peak effect of 1 to 84 is seen at 10 to 12 hours. And so the best way to administer PTH1 to 34, data from Weiner and colleagues, is a BID dose, and even better is a pump administration, which has been associated with even smaller doses of PTH required in a 24-hour time period to improve and optimize calcium homeostasis. With PTH1 to 84, we can administer this on a once-a-day basis, and we have good data with that, and I will be presenting that to you. PTH1 to 34 has been evaluated in open label studies. We've mentioned the data by Weiner and colleagues, and we have also data from Gaffney and colleagues and Palermo and colleagues, and we recognize that 1 to 34 enables us to reduce calcium and vitamin D requirements, and it will also decrease urine calcium losses and reduce the fluctuation of calcium. And it has been associated with increases in bone remodeling. And we have seen improved quality of life in the open label 24-month trial with PTH 20 micrograms BID. So the pivotal trial with PTH1 to 84, the REPLACE study, was published by Michael Manstad and colleagues in 2013. Our center participated in this study, and our patients who were in this study really noticed a significant impact on quality of life. This was a double-blind, randomized, placebo-controlled trial. This is a phase 3 study, 24 weeks, and the PTH therapy was started at 50 micrograms daily in comparison to placebo, and PTH was titrated as needed to 75 or 100 micrograms a day. And the primary endpoint was the proportion of patients at week 24 who achieved more than 50% reduction in both oral calcium and active vitamin D, and were able to maintain a serum calcium which was higher than baseline but less than the upper level of normal. And this primary endpoint was met in 53% of patients in the PTH arm, and one person in the placebo group met this endpoint. The secondary endpoint were the numbers of individuals who were able to stop active vitamin D and have a calcium requirement of less than 500 milligrams a day. And this was met in 43% of patients in the PTH arm. We saw reductions in phosphate into the normal range, and urine calcium was stable. The long-term data with PTH 1 to 84, we have the open label trial published with 6 years data in 33 patients, and we have 8-year data as well now. The PTH that was given was in doses that were titrated up to 100 micrograms a day, and calcium and vitamin D requirements were reduced. Serum calcium remained stable. Urine calcium was noted to decrease at year 6. And what was seen, the skeletal effects of long-term PTH were increases in lumbar spine BMD, femoral neck was stable, and the 1/3 radial BMD did decrease. So Michela Rubin demonstrated that the effects of PTH in hypoparathyroid patients at the skeletal level was similar to what we have seen in postmenopausal osteoporosis patients. There is quality of life data from Tamara Vokes and colleagues. This is looking at the REPLACE data, and treatment group did show improvements in physical component, body pain, general health, and vitality scores. So PTH has been demonstrated to reduce the dose of calcium and calcitriol required in hypoparathyroidism while maintaining acceptable or normal serum calcium. It does lower phosphate. It has a variable result on urine calcium, and the plasma calcium returns to baseline 24 hours after administration of the 1 to 84 molecule. The effects on quality of life are variable. There is another molecule, the TransCon PTH, which is a sustained release prodrug. And this is really administering the inactive form of PTH 1 to 34. And this is the PTH molecule attached with a linker to a carrier molecule. And then the carrier is slowly cleaved, releasing the PTH, and then the carrier is eliminated through the kidney. But this has been demonstrated to provide stable PTH levels in the physiologic range for 24 hours per day. And the half-life of the TransCon PTH has been noted to be 60 hours in a phase 1 trial in normal healthy volunteers. And the phase 2 trial is currently in process. So how do we manage hypoparathyroidism during pregnancy? And this is our next learning objective. And we recently reviewed the literature and provided evidence-based recommendations. Bart, Clark, Lars, Maria Luisa, and myself just recently put this paper together, and we've summarized what is known with respect to the calcium homeostasis in pregnancy and how to best manage this condition in patients who are pregnant. And Chris Kovacs has done a lot of important work in this area, and this is from his paper summarizing the changes in the hormones regulating calcium during pregnancy. And we can see that ionized calcium is actually stable and during pregnancy, and this is longitudinal data from a number of investigators globally. So ionized calcium will be stable. It is important to recognize that albumin levels decrease during pregnancy with hemodilution, and it is absolutely critical to correct the calcium for albumin. Phosphate levels are stable. PTH levels do decline during pregnancy. And we need to be cognizant of that fact because it will have an impact on our ability to diagnose hypo and hyperparathyroidism during pregnancy. And so we have very good data from our Dawi and colleagues, Gallagher, Bertolini, Yadav and colleagues, demonstrating longitudinal data that rises occur in PTH-RP. And this upregulates calcitriol and suppresses PTH. And where is this PTH-RP coming from? Well, it's coming from the placenta and it's coming from the breasts. And so this is the reason why we see rises in calcitriol as well. And so PTH-RP is rising and calcitriol is being formed through the maternal kidneys. And these rises in calcitriol are quite significant. They increase by 2 to 3-fold by term. And we have seen that anephric women on dialysis do not see this rise in calcitriol. So the rises in PTH-RP and calcitriol can result in a reduction in the requirements of calcium and calcitriol doses during pregnancy in patients with hypoparathyroidism. And so we summarize this in our paper. We recognize that the breast and the placenta will lead to an increase in PTH-RP, which will then increase bone resorption. It will also increase the formation of 125D, and the increases in 125D will increase intestinal calcium and phosphate absorption and increase urine calcium. And pregnancy is associated with increased risk of renal stones as well. So this is what happens with calcium homeostasis during pregnancy. And this is a nice diagram from Chris Kovacs' paper demonstrating that this enables the mother to meet the fetal requirements for the developing fetal skeleton. It's important for us to recognize that the calcium requirements increase during pregnancy, to meet the fetal demands, and the rises in 125D and PTHrP during pregnancy may result in lower dose requirements for calcium and active vitamin D metabolites. But in some patients, an increase has been observed, and in others, there may be no change in the requirements. So it's very important that we have close monitoring of our patients, because we don't know how our patient may respond to the changes with pregnancy. And we need to ensure that we are keeping our patient's serum calcium in that low normal reference range. It is absolutely crucial to ensure that the patient does not develop hypocalcemia or hypercalcemia. So the management recommendations are to adjust the dose of calcium and active vitamin D, targeting a low to mid-normal serum calcium. We want to avoid hydrochlorothiazide during pregnancy. We want to avoid PTH during pregnancy. And we want to ensure that the pediatrician is alert, because the neonate has to be evaluated at birth, and we need to monitor serum calcium. So there are complications of hypoparathyroidism in pregnancy, and patients may have a small for gestational age babies. They may have respiratory distress syndrome, and they're also more likely to have miscarriage and preterm labor in association with low calcium. And one of my pregnant patients with hypoparathyroidism was complaining of uterine contractions, and her serum calcium, when I was measuring it, was normal. But I increased her calcium and calcitriol dose, and the contractions resolved. And she, carried her pregnancy to term and had a beautiful baby. But we have to remember that when we measure serum calcium, we're measuring that serum calcium at that point in time. So if the patient is complaining of uterine contractions, think about the possibility that the serum calcium may have decreased. And we're not measuring calcium 24/7. So we need to ensure that we're listening to our patients and ensuring that we are meeting their needs to the best of our ability. So the treatment targets are to avoid hypocalcemia and to avoid hypercalcemia. It's important to avoid hypocalcemia because of the increased maternal and fetal risks, and also because of the fact that if we have hypocalcemia, this will increase the risk of secondary fetal hyperparathyroidism, and that can be associated with skeletal demineralization, and even intrauterine fractures have been reported. It's important to ensure that the patient does not have hypercalcemia. If we run their calcium high, this may result in suppression of the fetal parathyroid glands, and the neonate may develop hypocalcemia. So the treatment target is to keep that calcium in the low to mid-normal reference range and monitor closely. Monitor your lab profile every 2 to 3 weeks. And if we make changes in calcium or calcitriol, we should repeat that serum calcium in 1 to 2 weeks. And we should be monitoring phosphate and urine calcium, magnesium, and vitamin D, and ensure that we maintain that in the normal reference range. Remember that the FDA has risk categories for drug safety in pregnancy. A Class A drug is a drug that does not pose any risk to the fetus. And there are very few drugs in this class, and this basically includes prenatal vitamins. Class B drugs are drugs that in animal studies have failed to demonstrate a risk to the fetus, but we don't have adequately controlled studies in pregnant women. So they appear to be relatively safe. Class C drugs are drugs that in animal studies have been shown to have an adverse effect to the fetus, and there are no well-controlled studies in humans. And you would only use a Class C drug if the potential benefit is greater than the risk. So you would only do it in that situation. The Class D drug is there is evidence of harm in the human, and you would only use this in life-threatening situations. So in our pregnant hypoparathyroid patient, we're going to be monitoring their dose and adjusting it depending on their calcium requirements, and adjust the calcium and the calcitriol dose monitor closely, advise them of the symptoms of both hypo and hypercalcemia. I give my patients a lab requisition and say, if you are having any of these symptoms, get your calcium checked. And then we will communicate and ensure that your calcium is in that mid to low normal reference range. And remember, we need to have a team approach. We need the endocrinologist, we need the obstetrician, we need the pediatrician to optimize maternal and fetal outcomes. Hydrochlorothiazide is a category B drug, and it is associated with decreased fetal placental perfusion. So it is suggested to be avoided. And I stop patients if they're on hydrochlorothiazide. If they're pregnant, I stop this drug. Teriparatide is classified as a class C drug, and I would not recommend the use of teriparatide or PTH 1 to 84. There are no data on the use of PTH 1 to 84, and I would recommend that this not be used at this time in pregnant women. Let's move on to our last learning objective, which is PTH replacement. And how do we start PTH and how do we stop it? So these are the recommendations from the first international conference on management of hypoparathyroidism by Brandy and colleagues, and we all agreed that these are the indications for PTH: people who have poor control of serum calcium with frequent hypo and hypercalcemia, individuals who are requiring high doses of calcium or activated vitamin D, people who have hypercalciuria, renal stones, nephrocalcinosis, or chronic kidney disease should be considered for PTH replacement therapy. If we can't get that phosphate down with a low phosphate diet and with phosphate binders, then we should definitely consider PTH. If the calcium phosphate product is high, definitely consider PTH 1 to 84. If patients have malabsorption or they can't comply with the high pill requirements with hypoparathyroidism, or they have poor quality of life, we should consider PTH 1 to 84. One of my patients is a judge, and she was not able to function after her total thyroidectomy when she developed hypoparathyroidism, even though her calcium levels were normal. And it was when we started her on PTH that she felt normal brain function. And she said, yes, now my cognition has, I can now function as a judge. So it's important for us to recognize that even though the numbers look normal, we have to listen to our patient and consider the impact on quality of life. So how do we start PTH therapy? Well, we start with 50 micrograms daily sub-Q into the thigh, and we will decrease the dose of active vitamin D by 50%. It's important for us to monitor calcium and vitamin D every 3 to 7 days and reduce the calcium and calcitriol gradually. The goal is to reduce the calcium to 500 milligrams daily with a low normal serum calcium. And we would increase the dose of PTH by 25 micrograms up to 100 micrograms a day. What about potential harms of PTH therapy? Well, we have the potential risk of osteosarcoma, but remember, this was only seen in rat studies with toxic doses of PTH, and we have not seen an increase in the risk of osteosarcoma in humans who have been exposed to PTH, and we now have more than 2 million people who have been exposed to PTH, and we have not seen an increase in the risk of osteosarcoma. It's still the same 1 in 250,000. And the osteosarcoma surveillance study has not noted an increase in the risk of osteosarcoma. So it's really a theoretical risk, and it was seen only in the rats that were given 60 times the dose. So this is what I tell my patients. And the long-term studies that have been completed with PTH from John Delzikian's group, Michaela Rubin, published the 6-year data, and we have 8-year data now as well, demonstrating that PTH 1 to 84 is safe. And we have not seen an increase in the risk of osteosarcoma with the doses that our patients require for hypoparathyroidism or with obviously osteoporosis. Now, in September of 2019, there was the FDA recall of Natpara, and this was because of concern of rubber particles being released into the solution. And because of this, there was a recall of Natpara, and the ASBMR and the Endocrine Society issued joint guidance on transitioning patients with hypoparathyroidism from Natpara 1 to 84. And we recognize that when patients have been started on PTH therapy, there is an increase in bone remodeling. And so patients' requirements for calcium and calcitriol when they stop PTH 1 to 84 may be 2 to 3 times what they were prior to starting PTH 1 to 84. So it's important that we recognize that. And when we switch to calcium and calcitriol, that we increase the dose, double the dose, and monitor these patients very closely. We don't want them to become hypocalcemic. If we switch to teriparatide, we could give teriparatide twice a day or even 3 times a day. But patients' requirements for calcium and calcitriol appear to be 2 to 3 times what they were prior to starting PTH. And if we switch to teriparatide from Natpara, the 1 to 84 molecule, consider twice a day dosing or even 3 times a day dosing. Sudden discontinuation of PTH has been associated with hypocalcemia, as published by Gaffney and colleagues. Gradual tapering off PTH therapy with resumption of calcitriol and calcium at doses 2 to 3 times what we were using at baseline is ideal because of the concern of increases in bone remodeling and the increased requirements for calcium and calcitriol. Bottom line is monitor the patients very closely to avoid both hypocalcemia as well as hypercalcemia. So in conclusion, hypoparathyroidism requires careful evaluation. It is associated with significant morbidity. We need to evaluate our patients closely, especially during pregnancy, and definitely consider PTH therapy if optimal control is not achieved with conventional therapy. And we need to monitor our patients closely during pregnancy to achieve optimal maternal and fetal outcomes. So with that, I really would like to thank you all for your attention and answer any questions that you may have.
Thank you very much, Professor Khan, for your excellent talk and for covering the diagnosis and management of hypoparathyroidism. Thank you for summarizing the risk, benefits, and limitation of pharmacological intervention and for providing guidance regarding hypoparathyroidism during pregnancy and for appropriate initiation and cessation of PTH treatment. Thank you also for sharing your experience with your patients. I'm sure this was greatly appreciated by our audience. Now I would like to move on to questions, as we have received a number of them during this presentation. And maybe I will start with this first one. Why are there variations in the dose of calcium and calcitriol requirement in pregnancy?
Yes, that's a great question. And it's important for us to remember that there may be differences in calcium intake in pregnant women. And it's also a possibility that the amount of PTHRP which is being produced and the amount of calcitriol which is being produced in the maternal kidneys may vary. And so because of this, we can't really predict how much a patient may require during pregnancy, and we really need to be guided by that patient's response. In some patients, I've reduced the doses of calcium and calcitriol, and in other patients, I've had to increase the dose of calcium and calcitriol. So it's important that we recognize that there are variations, and the most significant factor, I would say, is variations in calcium intake amongst our patients and variations in diet.
Thank you. There is another question related to pregnancy. Are we concerned about calcitriol crossing the placenta in pregnant hypoparathyroid patient?
And that's an excellent question. And calcitriol does not cross the placenta. And circulating calcitriol in the fetus is actually made in the fetal kidneys or the placenta. And the mother's PTH also doesn't cross the placenta. So the PTH, which is synthesized in the parathyroid glands in the fetus, is really the PTH that's present in the fetus. So the bottom line to that question is calcitriol doesn't cross the placenta. The calcitriol is safe to use in pregnancy. Calcium and calcitriol both are safe. I would not recommend using PTH. I would not recommend using hydrochlorothiazide. And I would recommend correcting magnesium in hypoparathyroid pregnant patients.
Thank you. Another question related to PTH. At what time of the day should PTH level be checked? Any recommendation?
Well, I would say that the best time to check the PTH would be pre-dose.
Okay. Another question, why is the mortality greater in non-surgical hypoparathyroidism in comparison to post-surgical hypoparathyroidism?
That's a really great question. And it's important for us to remember that in non-surgical hypoparathyroidism, these patients may have autoimmune polyendocrine syndrome, for example. And that can be associated with adrenal insufficiency. They may be on steroids. With the mucocutaneous candidiasis, there is an increased risk of cancer. Actually, they could get squamous cell cancer involving the oral mucosa and also in the esophagus. So the patients who have non-surgical hypoparathyroidism, actually from the Danish cohort study and also from the Scottish data, do have an increase in morbidity and mortality. And it's because they have other reasons to have hypoparathyroidism, and it's not just clear-cut following surgery. So the autoimmune polyendocrine syndrome is an important factor that can cause hypoparathyroidism. Also the genetic conditions, you know, with DiGeorge syndrome, these patients might have cardiac abnormalities. And so the genetic abnormalities that are associated with hypoparathyroidism, the syndromes can be associated with renal anomalies as well. And so there are other reasons to have an impact on morbidity and mortality. For example, with fractures, you know, we have seen differences in fractures, in upper arm fractures between post-surgical and non-surgical patients. And as the questioner is asking, there are differences in mortality in the non-surgical and the post-surgical group. In the non-surgical group, we did see an increase in mortality, whereas we didn't see that in the post-surgical group. And that increase in the non-surgical group was also seen in cardiovascular disease and cerebrovascular disease. Whereas other morbidities like mental illness and renal failure seem to be present in both conditions. And so there are similarities between post-surgical and non-surgical, but there are also important differences. And the important differences relate to the fact that they are associated with different underlying disease states.
Okay, thanks for this great answer. Now I have two similar questions. What is the meaning of measuring 25-OH vitamin D in hypoparathyroidism?
So that's a really great question. And we know that in patients with hypoparathyroidism, patients' conversion of 25D to 125D will be impaired. And some people may say, don't bother measuring 25D. But we know that PTH, even if it's present in small amounts, will convert 25D to 125D. And patients who have had post-surgical hypoparathyroidism may still have some PTH production. And that PTH production will be able to convert whatever 25D is available and result formation of 125D. So I measure both 25D and 125D, and we want to optimize our patient's calcium and phosphate and magnesium levels, and we will work with that individual patient and ensure that we're normalizing these values. Patients who also have obesity, and this may be the situation in patients who have, for example, pseudo-hypoparathyroidism. The obesity may result in lower levels of 25D. And we know that this is a PTH resistant state, but there is effect of PTH present as well. And we can result in lowering of PTH levels in patients with pseudo-hypoparathyroidism if we overtreat them with calcitriol and excess calcium supplementation. So we don't want to overtreat them, and we don't want to suppress their PTH, because that will affect their renal calcium reabsorption distally in the kidney. And so it's important, in summary, to respond to that question is to evaluate 25D and try and normalize that and keep it in the 75 to 125 nanomoles per liter. We need more data, obviously, in the hypoparathyroid patient population to know what is the optimal level. But I do try and normalize the 25 hydroxyvitamin D level, and patients who have some degree of PTH available still will be able to convert that to 125D.
Thank you, and I think we will conclude this Q&A session with a final question related to idiopathic hypoparathyroidism. Could it be present in more than one family member?
It could be. We need to understand more about this condition. Our genetic understanding is still in its infancy. And I would say that in a patient in whom we have not been able to clarify the underlying cause of the hypoparathyroidism, I do proceed with the DNA panel that I have presented. And if the results do not confirm a diagnosis, then it's due to a mutation that we have not been able to fully evaluate at this time. But genetics is a field that is very much in its infancy and is rapidly growing. And what we think is idiopathic today, we may be able to characterize it and obtain a molecular diagnosis in the very near future.
Thank you. And I think with this question, we will end our webinar. I would like first to thank you very much for your participation in this webinar, and we hope that you enjoyed this session. We will post recordings of this webinar on the IWEF website, and you will also receive the link by email tomorrow. You will be prompted to fill in a survey immediately after this webinar. We would appreciate your input and comments as we continuously try to deliver webinars that meet your needs. Last but not the least, if you have any questions, comments, please do not hesitate to send them over to webinar@iofbonehealth.org. And I would like really to thank you, Professor Khan, for your excellent talk and for answering all these questions. And I would like to say goodbye to everybody. Have a nice day or a good evening. Bye-bye.
Thank you, Dominique.